Hi folks, it's a concerned Dr. Miskoff, and I'm vlogging from my backyard here in Toms River, New Jersey on April 28th, 2020, about 3 p.m. It's an absolutely gorgeous day. I'll give you a little pin. We got the pool open and cleaned already, getting ready to enjoy the summer, getting a little extra vitamin D. I got the glasses off, just chilling out on my day off here, trying to enjoy just nature. I've spoken on the potential therapeutic benefits of vitamin D, and certainly can hurt to get a little extra today. With that said, I wanted to update everybody on hematology and COVID-19. I did go for antibody testing this morning in Toms River at one of the immediate cares, and they did get me for the copay about $70 or $75 for the urgent care visit, even though I technically am asymptomatic. I'm asymptomatic. The symptoms I had maybe 5 or 6 weeks ago were just some fatigue and maybe a headache. I'm wondering if that was just getting used to the whole COVID-19, adjusting diet, way of life. So I'll be curious to see what the IgG level is, the antibody. Remember, there's IgG, IgM. They're checking at least right now. This goes through Quest, and they give me information on the portal and how to get in 2 to 3 days to check it. I'm thinking that healthcare providers, probably around a 20 or so % probability. The people I've spoken to so far, I only know one that is positive out of 4 or 5. I remember New York reported some data on the public, about 13.8 or 14% from a sample size of, I believe it was 3,000 or so, and New York City was 20%. So it'll be curious to see. There's some reports coming out of smaller communities that are higher. It just depends on where you are in the country and how populated that area is, I believe. But healthcare, and of course exposure risk, which healthcare providers certainly have. Again, I'll keep you guys updated on that. LabCorp announced, I believe, yesterday that they're also doing antibody testing. So you don't have to go for a visit, if you will, in regards to having a clinician check you. When I went today, I was the first spot. It was 8:30. They checked vital signs. I'm happy to report my pulse ox was 98% with an N95 mask on. It even went up to 99%. I was wondering, if I was rebreathing carbon dioxide, if my level would be lower. But I think it's the best pulse ox I've ever had. And then blood pressure and heart rate were good. They check that. They do a quick exam, heart and lungs, and then you move into the chair for Quest lab draw. And lady did get it on the first stick, and hopefully we'll have those results in 2 to 3 days. If you were to set it up at LabCorp, you would need a prescription from your provider. You could specify at LabCorp, I believe, don't quote me on it, but I believe I read either IgG, meaning that you've cleared the infection or have had, at least been asymptomatic for 10 to 14 days. And you can also get the IgM with LabCorp, so that would be in the first couple days the IgM would go up, and then after about 2 weeks or so, the IgG goes up after the initial infection. And then they're doing an IgA level. I'm not exactly sure how they're going to utilize that. But, I think getting antibodies tested, at least for frontline workers, people with heavy risk exposure, is a good idea. It takes some of the angst away, although we don't know if this is a perfect test. The sensitivity and specificity is supposed to be quite good. Positive predictive, negative predictive value is supposed to be quite good. There is some cross-reactivity with non-novel coronavirus strains that if you had another type of coronavirus, not COVID-19, that you could be positive on the test as well. But it's supposed to be a very, very small percentage. I haven't seen the actual numbers directly from Quest yet reported on the sensitivity and specificity, but I'm sure you could find it somewhere. Again, if it's negative, then you probably didn't have it. It's unlikely that you're not going to form antibodies unless you had a very mild or almost asymptomatic state, and it was recent, in the last couple weeks. It's possible. If I test negative, I figured I'd probably go for the LabCorp test in about 6 weeks with the triple antibody test and just keep an eye on it. By doing these antibody tests, the more people that do them, the better idea we'll get on the epidemiology side of this. What's the true death rate? We don't know at this point, but we're as more and more both RNA or tests, nasal swabs get done, and as we do more antibody testing, they'll be able to put those into the models and better predict the data. In regards to other issues with heme, I wanted to discuss clotting. As we've discussed before on other vlogs, there does seem to be an increased risk of microvascular clotting in these patients. We are putting them on therapeutic Lovenox or enoxaparin. If they clinically get worse, some of us, and others are waiting for certain values, tracking the D-dimer levels, trending those markers, and when it gets to 5 or 6 times the upper limit of normal, potentially starting it. Other institutions are still using unfractionated IV drips of heparin. Some thought that may be anti-inflammatory more than the other products, the old long-chain unfractionated heparin. Some are still using sub-Q versions if they have renal failure or kidney failure. You're dose adjusting appropriately. And Mount Sinai reported using TPA, thrombolytic therapy, or TPA, tissue plasminogen activator, in a series of just 5 patients. But when you can't oxygenate a patient when you're losing them, I commend them for going outside the box and trying something a little bit different. We talked about Northwell's system, looking at 23 hospitals in their system with Pepcid at 9 times the dose, as we talked about on the vlog the other night, where that at least in 6,000 or so Chinese retrospective chart reviews, it seemed that the patients who could not afford the higher priced proton pump inhibitors like Prilosec, omeprazole, Protonix, etc., were actually using Pepcid, and there was a note that they actually had lower death rates, maybe even half as much of a death rate. So I'd be curious to see what goes on with that. I spoke to my clinical pharmacist the other day, and they weren't opposed to using Pepcid. In fact, almost prefer it. With the proton pump inhibitors, there's been the story of overgrowth of the gut flora and even maybe a risk of C. diff colitis. So this may be safer route to go anyway. Keep your eye on the platelet counts. Sometimes when those drop, we blame it on a H2 antagonist such as famotidine. Anyway, exactly what to do in the Sinai little case series that was reported. I believe the patients had an improvement in oxygenation initially, so their oxygen levels were improved, but it wasn't sustained. They went on, therefore, to study these patients with a slower drip at a lower rate, and I believe they reported that the oxygenation stayed better for a longer amount of time. So whether we're using sub-Q heparin, whether we're using Lovenox or enoxaparin, whether we're using Eliquis, Xarelto, Pradaxa, the other DOAC medications, or even taking it all the way to the clotbuster TPA, the data is still not compiled. We still don't know the safest, most effective way. Hopefully time will tell and give us more guidelines and guidance. As far as what you do with these patients when they survive COVID, well, if they survive COVID, then the hope is that the D-dimers have trended down. Now you're getting them ready for a rehab or discharge. A lot of these patients are requiring home oxygen, and the insurance companies have loosened up, and they do accept COVID-19 as a diagnosis. Historically, you needed a pulse oximetry of 88% or less and a diagnosis of a chronic respiratory condition such as COPD, but now pulmonary hypertension, etc. But now you can actually get it with just the COVID-19 diagnosis. But what do you do with the anticoagulation? Do you send these people out on 1 month of therapy, 2 weeks of, Eliquis, Xarelto, Bavexxa? Bavexxa was one that was, it's Betrixaban, and that was FDA approved for extended prophylaxis for high-risk DVT patients a year or 2 ago. But most people don't even know that, and there isn't a common practice of sending people out on anticoagulants just for prophylaxis extended. But you do have Xarelto was FDA approved, and Bavexxa was FDA approved for extended treatment for DVT prophylaxis, but nobody knows with COVID-19. Do you send them for a D-dimer in 2 weeks out the door and treat them for a couple weeks? I think time will tell what we do with them. We were reluctant to give aspirin products and NSAIDs, of course, in the beginning. We talked about ACE2 upregulation and maybe making the virus entry into the cells easier. However, if they survived it and they're now leaving, we're not too concerned about the virus now upregulating, so maybe aspirin's the answer. Certainly inexpensive, well-studied in other conditions. Nobody knows what to do. What I can tell you is that I'm not anecdotally seeing patients get readmitted with clots, although there are people reporting that patients are coming in, younger patients with strokes. We saw pictures of the discolored toes in adolescent boys and even adults. That's a curious situation, and we think that's probably microvascular clots again. Is there clots going on throughout the lungs, kidneys, brain, heart, musculature? Patients are reporting pain as a less common symptom, back pain, pins and needle feeling, electric shocks. Some of this is happening on the recovery phase. So it's just all very curious stuff, and we don't know enough yet to explain it all for sure, and we're getting little bits and pieces of the puzzle that we're putting together and trying to figure out the best therapies to go with that. Sarilumab reported, I believe, yesterday that at least the early patients, the anti-IL-6 trial, I think they're actually stopping recruitment on the earlier, the less severe patients, but that they did see some benefit in the severe population, that the C-reactive proteins dropped significantly, and that there may be a benefit in that more severe, but I'm not sure they're going to allow recruitment of the less severe, the better pulse oximetry patients coming in. I made a comment that, whatever therapy it is, it should be given early. Well, this may be a case where that's wrong, and that anti-IL-6 really should just be for that more severe cytokine storm and not early on, as I alluded to, at least with the antivirals. The hydroxychloroquine story, fading fast, less and less clinicians, cardiologists jumping on. There is risk. Organizations are putting some risk out there, but of course, when the patient comes in that sick in the hospital, and we have the ability to do the EKG daily, to get the QT interval to see what it is, at least we can monitor them. So that's still up in the air, but we do see that fading a bit, and we see the numbers going down a little bit. The last couple days, it does seem like admissions are dropping. I believe the numbers support that. That's positive. We're hearing tidbits on, the vaccines and maybe faster than they thought. And then you hear the contrary. I think Oxford reported working pretty fast on one. Worked in monkeys, they said. They are testing humans around the world with some of the vaccine trials already. And again, what will happen with remdesivir and that whole story. So again, in conclusion, went for my antibodies. I'll keep you posted on that. I think it helps with the epidemiology. It certainly would help me at least mentally a little bit if I knew I was positive. I think that this was in New Jersey, New York City, prior to mid-January, when Washington State first reported it. I wouldn't be surprised if ultimately, it was found that, and I don't know if we'll ever figure that out, but that it really popped in December. Lots of people reported being sick at the end of December, January. Certainly was exposed heavy in the office, 30, 40 patients a day. A lot of them had cold symptoms and cough, and we were swabbing them, but we didn't have the novel coronavirus swab at the time in the office. And our offices remain closed for the most part, except for telemedicine with one of the docs, as the docs are still over at the hospital. And seeing the numbers drop, some encouragement that we may be able to return to the office setting, hopefully as soon as maybe even June 1st, but no promises. For now, everybody stay well. Give you more updates on the whole story of what anticoagulant may be best for patients who are hospitalized and for those who go home. And I'll keep you updated on the other medications as the trials come in. And again, everybody get outside, enjoy some beautiful vitamin D. I just finished my cup of orange juice or vitamin C and trying to take the natural approach today.